Yeah, because we're talking about peaceful.
How is everyone? Wonderful, good. Okay, we'll go ahead and get started. So I think the last time we met on Monday, we kind of left off on this screen. And just to reiterate, we've transitioned into the cephalosporins. We made mention of the fact that the cephalosporin class, which is divided up currently into 5 different generations, has a mechanism of action identical to what we described for the penicillins. Okay, it acylates the serine residue and the penicillin binding protein active site. Okay? By binding to that serine residue, it inhibits the ability of the enzyme to catalyze transpeptidation reactions. That then decreases cell wall synthesis, cell wall repair. It weakens the cell wall in susceptible bacteria. That causes the bacterial cell to lyse under that osmotic pressure that exists from within the cell. We made mention of the fact that a penicillin moiety is a 4-membered ring that is annealed to a 5-membered heterocycle. The difference between the penicillins and the cephalosporins is the elaboration of the ring by 1 carbon. We go from a 4-membered beta-lactam annealed to the 5-membered thiazolidine ring to a 4-membered beta-lactam annealed to a 6-membered dihydrothiazine ring. Okay, so it's a little bit larger because that extra carbon in the 6-membered system is bigger than the 5-membered system and imparts a little bit less ring strain on the penicillin, the beta-lactam ring. That less ring strain creates or contributes then to a little bit increased stability. All right. From a structure activity perspective, there have been so many cephalosporins produced over the years. There are a lot of cephalosporins that have been clinically used. But again, for those of you that are initiated to the hospital setting, you'll come to realize it's the same ones over and over and over. All right, so those are the ones that I'm going to pay particular attention to. And I'll tell you a little bit about why we use them in certain circumstances and what structural features in particular lend to their widespread use. All right, so again, just to show you, here is the most critical aspect of the cephalosporins. There's our beta-lactam, and there's the beta-lactam bond that has to be maintained until it gets into the penicillin binding protein active site. There's that dihydrothiazine ring that I made mention of. That's the 6-membered system. So 4 plus 6, that's the quote-unquote pharmacophore then for the cephalosporins. This carboxylic acid is required because, again, that's what then helps to mimic the C-terminus in D-alanine, D-alanine. That's what helps to trick, so to say, the bacterial enzyme to take these up into the active site. Now, as we work our way around this system, we get to the 3 position. And in this particular model, you'll note that the 3 position is just an acetate. So there's the hydroxyl group has been protected and it's now an acetate. And there's a couple cephalosporins that have been produced that maintain that particular display. But what we see is this 3 position has been elaborated significantly in some of the newer derivatives. You'll note when I show you there's some charge issues that have been associated with the 3 position, incorporating a lot of basicity and positive charges into that 3 position substituent actually does wonders for some of these molecules to get into the periplasmic space of susceptible bacteria. A lot of basicity coming off that 3 position also helps then to decrease affinity for some of the cephalosporins to certain beta-lactamase enzymes, right? So it decreases the affinity of the drug as a substrate for hydrolysis reactions from the beta lactamases. The other thing that you'll note with some of the derivatives, depending on the substituent at the 3 position, you can largely influence then the kinetics of the drug. Okay. Most of the cephalosporins, classical cephalosporins, were given probably every 6 hours, maybe every 8 hours. That's quite a frequency. Okay? Every 6 hours, every 8 hours. Some of the drugs that I'll make mention of briefly have substituents coming up in 3 position that allow for every 12 hours or even every 24 hours, depending on the drug. Okay, so if I want you to know anything specific as it relates to the 3 position, bless you, I will let you know. Okay. As we make our way around, again, we get to the 6th position and then the 7th position. And in most cephalosporins, you have those alpha protons, just like you saw with the penicillins. After this slide, you won't see too much of those represented because, again, too, they just get in the way. But I do want to make mention of one interesting substituent. Right? There is a subclass of cephalosporins, a 2nd generation subclass that are referred to as the cephomycins. The cephomycins include drugs like cefoxitin and then cefotetan. And these 2 cephalosporins have at that 7th position a methoxy substituent instead of a proton. Right? And this is what a methoxy group is, or a methyl ether, if you prefer. And for whatever reasons that I can't find, reasons that aren't obvious to me from the literature, that methoxy substituent in that drug or those drugs actually enhances or imparts anaerobic coverage for these 2 drugs. Cefotetan and cefoxitin have anaerobic coverage, right? So what we would see is these drugs being used as prophylaxis. So if a surgeon was going to do an abdominal surgery, one of the concerns, of course, is nicking the bowel. And as you nick the bowel, anaerobes can leak out and infect the peritoneal cavity. So as prophylaxis, you might give a couple doses of cefotetan, all right? If they have a bona fide intra-abdominal infection years ago, you might see cefoxitin or cefotetan being used to treat that intra-abdominal infection, in particular if it was from an anaerobe. So anaerobic coverage. When we get to intra-abdominal infections, unfortunately, what you're going to come to realize is that the susceptibility of a lot of anaerobes to those 2 cephalosporins, those cephomycins, has decreased over the years. Okay. And then that's where we get to this 7th position. This is where a lot of the business has been done on cephalosporins. There are so many different side chains that have been elaborated coming off the 7th position. It's been really remarkable. Depending on what you display on that 7 position side chain, you may actually have increased protection of the beta-lactam ring from beta-lactamases. Right? The side chain can dictate or govern whether or not your cephalosporin is going to get hydrolyzed by a particular beta-lactamase. So there's a couple substituents on the 7 position side chain that I'll make mention of that are important and protect. And then, oh, I'm sorry, I'm in the wrong spot. And then as far as coverage is concerned, some of the earlier cephalosporins, 1st generation agents, have good gram-positive coverage. Okay? And then as you move forward from the 1st generation to the 2nd generation, even into the 3rd generation cephalosporins, what you note is a slight decrease perhaps in gram-positive coverage, but you start to see increases in gram-negative coverage. So gram-positive coverage goes down a little bit, gram-negative coverage is enhanced. And what's suggested by that is the substituents, iazole ring in particular, coming off the 7th position, is responsible for enhanced gram-negative activity. And I will show you a picture of that as well. So to summarize, the beta-lactam ring, of course, is absolutely required, as well as that carboxylic acid coming off the 2 position. The bicyclic system is required, and then the alpha hydrogen at the 6th position is required for activity. Okay, and then this one just kind of, if you like color, I think this one just rendered a little bit better. So themes. These are some general themes then that I think I want you to be familiar with, okay? I'm not going to necessarily ask you to memorize these structures. I'm not going to ask you to memorize the structure of ceftazidime relative to cefepime, but I'll want you to understand what's similar about those two agents that lends to anti-pseudomonal activity, okay? All right, and that just kind of summarizes things. All right, this is where it starts to get a little bit quirky. So as far as generations are concerned, who's familiar with some cephalosporins that you could classify as first generation cephalosporins? Throw out a couple names if you know them. Keflex, and we also call Keflex. Good. Good. Tell me another one, another first generation agent. Good. And maybe one more that is of relevance yet today. Oral agent, probably underutilized. You guys dispense much cephadroxyl or Duracef? Underutilized. So cephalexin is PO, cephadroxyl is PO, and cefazolin is IV, right? So those are, in my opinion, and I think you guys might agree with me, the clinically relevant first generation cephalosporins, right? And these particular agents offer good coverage against Staph aureus and strep, right? Staph aureus, that is MSSA, methicillin susceptible, right? Good. How about some second generation agents? Tell me the name of a second generation agent you might be familiar with. Which one? Cefuroxime. What's the generic or the brand name for cefuroxime? Anybody know? What's that? Claverin. So claverin is cefotaxime. Close. We'll get to that one soon. Availability issues with that one. It is Ceftin. Good. Ceftin. Is Ceftin oral or IV? It's oral. It's that really cool looking blue tablet, isn't it? Is there an IV formulation of cefuroxime? Who are our hospital interns? Anyone? Have you ever seen this cefuroxime IV? No, it's called Zinacef. That's the trade name. It does come IV. It's not used all that often. My experience with this agent has been mostly in the pediatric population, and they used it for pneumonias back when I was working in the hospital. So just be aware, it does come PO. It is a second generation agent. It's under the trade name Ceftin, which you probably don't see on your e-prescriptions anymore. But those of you that work in the hospital setting or when you go to the hospital setting, just be aware. It is also available IV. Zinacef is the trade name. Probably not used all that often. Okay. Any other relevant second generation agents? Yeah. And then we might as well throw in cefoxitin as well. So those are those two cefamycin derivatives that I made mention of. They're second generation cephalosporins. They have the methoxy group coming off that 7 position, which then confers the anaerobic coverage. So these are going to be strictly used for anaerobic infections if we know that they're susceptible. Okay. Outside of that, guys, I don't think there's too many sexy second generation cephalosporins. Okay. You may hear one or two here now and then, but I think what we've gotten here is a pretty good list. Let's go to the third generation agents. Do you know any third generation cephalosporins? Yeah, that's the big one, right? Ceftriaxone is arguably the most widely used third generation agent. Any others? Ceftonir. What is Ceftonir? What's the brand name for Ceftonir? Omnicef. And that's PO. There's been some availability issues with that one too over the last year or so, hasn't there been? Shortages on all of these suspensions, so to say. All right, Ceftonir. Any others? Clafrin earlier. Cefotaxime is Clafrin, IV, third generation cephalosporin. You've heard Dr. Lewis talk about ceftazidime. Or Fortaz, as its trade name, right? Another third generation agent. And there's a constellation of oral third generation agents that will probably be mentioned throughout this semester as well. Okay. Cephalosporins. Anybody familiar with cephalosporins? What is cephalosporins' trade name? Vantin. Very good. Vantin. I thought it was a drug of historical interest, but now it's starting to get used more and more, in particular for the treatment of certain sexually transmitted infections. You know, usually we see antibiotics being given for 7 to 10 days, but when you see a dose, that kind of tells you then what kind of infection you might be treating. Okay. Good. How about the fourth generation agent? What is that drug? It starts with a C. Cefepime. Right. And then that brings us to the, at present, Lone Ranger in the fifth generation group. And what drug is that? Cefalaro, ceftaroline. All right. Okay, good. I don't know if this is helpful or not, but good gram-positive coverage here. We get gram-positive coverage and gram-negative coverage here. We get some gram-positive coverage, but we get good gram-negative coverage here. Okay. With cefepime, cefepime is remarkable because it kind of does both. It gives you really good gram-positive coverage and good gram-negative coverage. All right. And then if you haven't already heard Dr. Lewis mention this, ceftaroline is equivalent to Rocephin plus what other bug? What is it? MRSA, good. All right, so ceftaroline will give you a coverage equivalent to Rocephin plus MRSA. Okay. All right. And what's remarkable, what's remarkable about Cefalaro or ceftaroline, it is the only cephalosporin right now that is approved by FDA to cover MRSA. I'm just going to stop there for a second. Guys, if you can treat an infection with a beta-lactam, it's the best choice. Right? The beta-lactams are by far superior compared to any other class of antibiotic. If the bug is susceptible to a beta-lactam, use a beta-lactam. If a patient says they're allergic to a beta-lactam, it shouldn't just be a reflex to go on to a different drug. Learn more about that allergy, because how many times does somebody say they're allergic to a medicine when they're really not? It might just be an adverse effect, not a true allergy. Okay, by not using the beta-lactam and using a different drug, you might be sacrificing a little bit of efficacy. Okay, and you might be predisposing that patient to unnecessary adverse effects or drug interactions. Okay, so if we can use a beta-lactam, trust me, we want to use a beta-lactam. Man, that looks like terrible hieroglyphics on the screen here. Does this make sense? Is this your concept of cephalosporins and generations? I think if you can then conceptualize it and compartmentalize it like this, you'll do okay. Are there any questions or concerns about this outside of my poor penmanship?
Do any of these cover Pseudomonas? Because I thought there was Pseudomonas coverage.
Which one?
Do any of them?
Do any of them cover Pseudomonas? Great question. All right. When we think of Pseudomonas, what color do we think of? Green. So let's highlight or circle some anti-pseudomonal drugs listed on the screen. Does anybody have a thought? Cefepime. Anti-pseudomonal. Very good. Others. Are there others? Yeah. Ceftazidime. Very good. Oh, that was a quick list, wasn't it? Yeah. So what you come to realize is that the cephalosporins don't have great coverage against Pseudomonas. Okay. But our friends, the carbapenems, which we'll get to, do have pretty good coverage. Other questions? Thank you for bringing that up. Yes.
What do you mean by
Plus MRSA? Good. I'm glad you asked that because it's not very clear. I didn't explain it. When you look at the coverage of Rocephin offers you, it's kind of unique in the third generation class. It offers you good gram-positive coverage. In fact, Rocephin is often used to treat community-acquired pneumonia when there's a risk of being a strep pneumonia. So it gives you good gram-positive coverage. It will cover strep. It will cover Staph aureus, MSSA. Although we don't want to always use Rocephin for MSSA, we prefer to use the first generation. In addition to those two gram-positive organisms, it offers a wide variety of gram-negative coverage. It will not cover antacin producers. It will not cover ESBL producers. It will not cover Pseudomonas. But outside of that, it's got pretty broad gram-negative coverage. Now, when you take that list of organisms, superimpose it on the spectrum of activity for cephalosporin, and then you just add on MRS. Okay. Good. Other questions or concerns? So we just kind of talked about the generations then, and I hope that makes sense. And I hope you start to study those so that they're solidified in your mind. First generation agents, as you guys already stipulated, those three drugs. Gram-positive bacteria, very good coverage. What's unique and interesting about the first generation cephalosporins is their utility in the face of an MSSA infection, right? Remember, MSSA is resistant to penicillin because it's going to be producing a beta-lactamase, right? So we don't use penicillins to treat MSSA in the absence of an inhibitor. These drugs, being cephalosporins, don't bind the PC1 enzyme, the penicillinase that Staph produces. As such, they have the ability to bind penicillin binding proteins in MSSA and inhibit cell wall synthesis. Okay. MSSA and MRSA, common causes of skin and soft tissue infections that we'll talk about down the road. But again, too, if there is little risk for MRSA, this is a great first choice, an oral agent or IV cefazolin. Strep pyogenes, okay, group A strep. Common cause of cellulitis. It's a cause of erysipelas, which is a kind of like a lymphatic infection. First generation agents will cover strep pyogenes as well, all right, and group B strep for that matter. They do have some limited gram-negative coverage. I don't necessarily think you want to go and use a first generation agent right off the bat if you don't know or understand the local resistance pattern where you're practicing, okay? I do see a lot of cephalexin being used to treat UTIs, so that suggests there's still some coverage for, you know, wild type E. coli if it's out there. Or what's the other cause of UTIs? E. coli is by far the most common, but it's not the only cause of UTI. Did Dr. Lewis talk about a particular staph variant that causes UTI? What did she say the name of that organism was? Saprophyticus. Yeah, very good. Staph saprophyticus. So when that is a cause of UTI, you know, Keflex, not a bad option. All right. Here are the drugs. So here is your parenteral cefazolin or cefazolin, and then the two oral agents. Okay? Nothing too remarkable about these drugs outside of the larger ring system. And again, too, I want to impress upon you that size matters here. The sterics induced on a system as a consequence of that extra carbon actually then prevents a drug like cefazolin or cefadroxil or cephalexin from getting into the penicillinase active site. Right, so that narrow active site prevents the cephalosporin from getting in there, and as such, they don't get hydrolyzed. Okay. How do we know that that ring system is that important, though? When you look at this particular screen, in particular, two particulars, look at the bottom, right? And pay attention to the boxed area here and then the boxed area there. We have seen substituents on other derivatives that are identical to those two boxed regions. And the substituents in those two drugs don't confer any protection to the former agents, those being amoxil and then ampicillin. When you look at the side chain in ampicillin, it's identical to what you see there for cephalexin. When you look at the side chain of cefadroxil, it's identical to the side chain in amoxicillin. And amoxicillin and ampicillin are penicillinase-sensitive aminopenicillins. Based on that, you have to be thinking then that the larger ring system really plays an important role in the decreased hydrolysis by penicillinases, right? First generation agents. I won't spend too much time on the second generation agents. You guys mentioned cefuroxime, which I think is probably the most relevant today. Cefprozil and then cefaclor. I mean, I can't tell you the last time I saw those drugs dispensed or prescribed. And then we did talk about the cephamycins. Okay. And then what does that methoxy group confer for these two drugs? The provision of anaerobic coverage. Okay. Cefoxitin's downfall is that it is historically given every 6 hours. Cepotetan is typically administered every 12 hours, and that every 12-hour administration may be in part due to this side chain that's coming off the 3 position. This side chain is a methyl thiotetrazole ring system. You guys can just listen for a second if you want. It's kind of just a little bit of trivia. That methyl thiotetrazole ring system has been suggested to decrease the synthesis of prothrombin in certain patients. And so if you have decreased prothrombin and you induce a hypoprothrombemia in select patients, that actually is going to then increase the risk of bleed. So there was some drug interactions and some adverse effects that had been reported over the years of patients on certain anticoagulants and then receiving cefotetan. I don't know. If I'm a preceptor, I'm going to ask you some off-the-wall question like that just to see what you know, or just to embarrass you if you're answering all of my questions adequately. So now you're prepared, though. I can say right there, buddy. Not that you would do that. IV, you guys don't like my drugs. You haven't tried them yet either. You don't like my jokes. That was a joke, by the way. A joke there. All right. Bacteroides is our anaerobe of interest there. Okay. And then on to some of the oral agents. I think, again, I already told you that cefaclor and cefprozil are sort of gone by the wayside, but cefuroxime does seem to be used a little bit now and then. If I want you to know one thing about cefuroxime, I want you to know that this was the first cephalosporin that actually incorporated a side chain which conferred enhanced resistance to beta-lactamases. This group right here that I just circled is it's a methoxy amino group, or an oxime. All right, methoxy amino group or an oxime. And what was discovered is that oxime confers increased or enhanced protection against hydrolysis by certain beta-lactamases. Okay. And because of that, what you're going to notice is that in all of the subsequent generations, this oxime or a derivative thereof is retained. These third generation agents. So they're good for gram-negative bacteria. And then I already made mention of the fact that a drug like Rocephin has good gram-positive coverage as well. We see a lot of changes at the C3 and then the C7 position. You already told me the name of a lot of these. Here are some PO agents that may or may not be in clinical use. The methoxyamino group, increased resistance to beta-lactamase. One other addition that you'll note in the third generation series then is the incorporation of an aminothiazole ring on the side chain. That thiazole ring, aminothiazole ring is suggested to enhance gram-negative coverage. Let's survey a couple of these agents that you already made mention of. Cefotaxime or clafurin, which I don't even think it's available in the United States anymore. I think there's been such a shortage of this that it's not even really in the discussion with regard to clinical use. And then ceftazine or cefazox, I won't even ask you anything about that. That's another historic third generation agent. The ceftriaxone and then ceftazidime end up being still relevant. Okay. That's the pharmacophore. This ring system here is the aminothiazole ring that I made mention of on the previous slide. And what does that aminothiazole ring confer to this third generation series? Increased gram-negative coverage. And here's the oxime. The oxime is responsible for protecting the beta-lactam bond here, here, here. There's a dimethyl acetic acid oxime seen in ceftazidime, which largely does the same thing, protects against beta-lactamases. Okay. This thiotriazine dione ring system coming off the 3 position in ceftriaxone doesn't really do much for decreasing hydrolysis by beta-lactamases, doesn't really do much with regard to coverage, but what it does do is modulates the half-life of this drug. So we have an enhanced or an increased half-life as a consequence of that ring. And that's important because then you can get away with every 24-hour administration with Rocephin for the majority of infections in the majority of patients. Okay. I'm not sure if things have changed over the years or not, but our pharmacy and therapeutics committee at the hospital I worked at pretty much made a statement that anytime you get a Rocephin order that's written, 1 gram Q12 for an adult, it automatically gets changed to 1 gram every 24 hours because of the kinetics. But there were some caveats to that. Can you think of a reason why you wouldn't want to adhere to that therapeutic change? What might be a reason why a patient shouldn't get just 1 gram every 24 hours when it was written every 12 hours? What are some patient characteristics that might preclude the use of once daily Rocephin? Yeah.
Are you asking about like the metabolizer? Their rapid metabolizer?
Rapid metabolizer. That's a good thought. And if you knew ahead of time that they had a variant in their liver that led to, a rapid metabolizer phenotype, maybe that helps inform your decision on dosing with certain drugs. This isn't one of them, though. Not necessarily their metabolizer status or their renal function for that matter, because you don't really need to adjust with renal impairment in Rocephin.
Would it be for bacteria that have a high MIC to the drug, since you worry about time above MIC?
Okay, that's a good thought as well. And again, the half-life here after a gram is going to afford you with a time above MIC that is going to exceed the MIC for most organisms. Good thought, but I'm looking for something a little bit different. I think you guys are thinking too hard about it. Weight. Patient weight. So obese patients, they were defined as greater than or equal to 100 kilograms here, were exempt from that 1 gram every 24-hour substitution. So you give obese patients every 12-hour Rocephin. Okay. Pediatric patients. We don't have the data in pediatric patients to justify that therapeutic change. Okay, so if the peds patient comes in and they're ordered every 12-hour Rocephin, you're going to give them every 12-hour Rocephin in the absence of additional data. Okay. And then there's a particular infection that eliminated the once daily Rocephin administration, and that was bacterial meningitis. So if the patient comes in with a clinical workup consistent with bacterial meningitis, you give maximum dose Rocephin until you know that you can change it to something else. Okay, and maximum dose in an adult is 2 grams every 12 hours. Okay. Just a little side note or caveat there. When you look at the structure of ceftazidime, I hope 2 things stick out at you. Okay, I already made mention of one thing that ought to stick out at you. And that's this, bless you, that's this oxime moiety coming off the side chain. All right, we'll come back to that in a second. What else is unique about ceftazidime relative to the other agents shown on the screen? Yeah, the positive charge. So this substituent coming off the 3' position is a pyridinyl derivative. So that pyridine ring bound at the 3' position is bound in such a manner that it displays a permanent positive charge. Okay. Why is that important? Well, what has been suggested is that that positive charge enhances the ability of this drug to traverse porins seen in Pseudomonas. Okay. So the enhanced water solubility, the enhanced polarity of this molecule imparted by that positive charge increases its ability to get into the periplasmic space of Pseudomonas. So we call ceftazidime an anti-pseudomonal cephalosporin, right? What gram-positive organisms does ceftazidime have coverage against? Are you familiar with any? Or is ceftazidime used for gram-negative infections only? I'm hard-pressed to say you're going to find a gram-positive organism matched up with ceftazidime, right? And when you look at the structure of ceftazidime, this oxime moiety decreases affinity for gram-positive penicillin binding proteins, okay? In fact, you know what? Did Dr. Lewis make mention of another drug that has a similar side chain to ceftazidime in her drug bug matching that's also only used for gram-negative infections? Do you remember us talking about this last semester? No. You're familiar with aztreonam, right, or azactam. And azactam is a monobactam that's only used for gram-negative infections, including Pseudomonas. And when you look at the side chain, everything over here, ceftazidime and aztreonam are identical. And they're only used for gram-negative infections. In ceftazidime, the side chain decreases affinity for gram-positive penicillin binding proteins. The same thing holds true for azactam or aztreonam. Okay. What questions do you have about these three particular third generation agents? Okay. Who's with me? Everybody with me? Do we need to stand up and stretch? Do some calisthenics? We're good. Okay. This is a modified chart similar to the one that I handed out to you guys the other day. And again, too, Ambler class A, B, C, and D. Beta lactamase production, as shown below, again, is the principal mechanism for resistance to beta lactams. Okay. We can have loss of porins, so porin modification or loss of porins will also confer resistance to beta lactams. Them being water-soluble substances, they require the porins to traverse the outer membrane in gram-negative organisms. If the porins are modified or gone, the gram-negative organism most likely isn't going to be susceptible to the beta-lactam. Efflux is relevant for gram-negative organisms as well. A lot of gram-negative organisms will express efflux pumps that have the capacity to pump that beta-lactam right out of the periplasmic space. Right? And then that takes us to cefepime, which is the fourth generation agent. When you look at the structure of cefepime, again, it's got the methoxyamino group coming off the 7 position, as well as this aminothiazole ring. And so this helps to predict good gram-negative coverage. This helps to predict increased resistance to beta-lactamases. But then what's the similarity that exists between cefepime and then ceftazidime? It's the presence of this permanent positive charge in this methylpyrrolidine ring. So that positive charge, much like we described for ceftazidime, enhances its ability to pass through pseudomonal porins. So cefepime and ceftazidime are your anti-pseudomonal cephalosporins. AMP-C and ESBL use. Right, this is an area of controversy. Hey, what class is drug of choice for ESBL producers? Carbapenems, okay? That should be reflexive. I say ESBL, you say carbapenem. ESBL. Yeah, see, it's fun. Class is fun. All right. But if we could find strategies to minimize the use of carbapenems, if we could find strategies to be carbapenem sparing, that's a good thing. We want to do that. Some of the studies that have been done over the years looking at ESBL producers have shown us that the use of a drug like Zosyn compared to a carbapenem, is miserable. Mortality goes up significantly when you use Zosyn for an ESBL producing infection compared to a carbapenem. So Zosyn is not going to afford us with this carbapenem sparing situation we're looking for. Cefepime recently has been kind of poo-pooed now as well for ESBL producers. It's not really the most reliable agent to use for an ESBL producing organism, regardless of the dose. So I think it's largely discouraged to consider cefepime for ESBL producing infections. We really need to stick to a carbapenem because we haven't come up with a better alternative. And then what do we know about AMP-C? What Ambler classification do you stick AMP-C in? A, B, C, or D? Remember, what does C stand for? Cookie. What else does it stand for? Cephalosporins. Okay. So AMP-C is a class C beta-lactamase. AMC, it can be constitutively expressed. So if you have chromosomal localization of an AMC gene that's constantly turned on and that organism is a constitutive expressor, that's bad. Right? That's bad for a lot of antibiotics. AMC could be induced as well. Right? Some organisms harbor the AMC gene, and that AMC gene is largely repressed until that organism is exposed to a certain beta-lactam. The presence of the beta-lactam and the carnage that ensues de-represses the gene, leading to the production of AMC. Okay? AMC producers have been successfully treated with cefepime, provided you give an adequate dose. All right, so that's where the susceptible dose-dependent disclaimer comes in from the lab. All right, maximum dose of cefepime. Why might that be? Why might cefepime be an acceptable option for an AMC infection, an AMC producer? Is this drug not getting hydrolyzed at all by beta-lactamases, by the AMC gene product? Is there something about the structure here that decreases its affinity for the AMC active site? Or is it possible that the drug itself does get attacked, does get hydrolyzed, but is a poor leaving group after beta-lactam bond opening? Does it stick to the active site for a prolonged period of time, thereby inhibiting the enzyme? And the latter holds true. Okay, so cefepime will get hydrolyzed by AMC, but it doesn't get deacylated immediately. Right? The ability of the enzyme to deacylate it is suppressed because of the structure of cefepime. It binds, it gets opened up, but then it sticks to the enzyme. It stays around for a long time. So it's a substrate for AMC, but it is also an inhibitor of AMC. And in doing so, what you do, when you give an adequate dose, you sacrifice some of that dose to hydrolyze and then inhibit the beta-lactamase, but the rest of the dose ideally is then going on and inhibiting the appropriate penicillin binding protein. Okay. And then that brings us to ceftaroline, which is the 5th generation cephalosporin. What gene is responsible for producing the penicillin binding protein 2A transpeptidase? It is a BLA gene. No, actually, I'm sorry. It's not a, remember, penicillin binding protein 2A is not a beta-lactamase. Yes, MECA, that's what you were thinking about. MECA, the MECA gene is responsible for producing penicillin binding protein 2A. Penicillin binding protein 2A is that funky transpeptidase that has its active site protected until the allosteric site is triggered by peptidoglycan. All right. Ceftaroline is the cephalosporin that's capable of triggering that allosteric site and then subsequently inhibiting the active site. Ceftaroline doesn't give us activity against some of these funky beta-lactamases. Ceftaroline doesn't offer us pseudomonal coverage, okay? In fact, the only place in therapy, in my opinion, for ceftaroline is to treat an MRSA infection that isn't amenable to one of the other agents that are used for MRSA. Here's the structure of ceftaroline. And it comes as a prodrug, phosphamyl prodrug. This phosphate group is quickly hydrolyzed by phosphatases in the plasma after IV administration to afford us then with the active moiety. And again, too, just look at the structure really quick. You see some similarities from the earlier cephalosporins. Right? There's the pharmacophore. Here's our important beta-lactam bond. After that phosphate comes off, we get an aminothiodiazole ring, which again is suspected to enhance some gram-negative coverage. Instead of a methoxy amino group, we have an ethoxy amino group. Right? There's an oxime in the side chain, again, intended to protect against beta-lactamases. Okay? And then the business end of this molecule, which lends to its MRSA activity, is the side chain coming off the 3' position. And this is what contributes then to the MRSA activity. And again, if you think back to, our model for the penicillin binding protein 2A, active site and allosteric site. Here's the active site. Here's the allosteric site. Okay. I can't recall off the top of my head how many angstroms away the allosteric site is from the active site, but I'm pretty sure that an equivalent of cephalosporin cannot traverse both. Okay. What does that suggest? What that suggests to me, and then what's been shown in the crystal structure data, is that one equivalent of cephalosporin, by virtue of its side chain, binds to and triggers this allosteric site. All right. And by triggering this allosteric site and causing some electrostatic interactions, that causes then the exposure of the serine residue. And that's where the second equivalent then of cephalosporin is going to come in and attack that serine, right? And inhibit it. I admit it, I'm not a techie guy, so I just erased my drawing. I apologize for that. But conceptually, does that make sense, you guys? You need about 2 equivalents then of cephalosporin to inhibit penicillin binding protein 2A. One equivalent triggers the allosteric site, leading to then the exposure of the serine residue and the transpeptidase active site. Okay, it's 9:50. Why don't we take a break, come back at 10 and see how far we get, okay? Okay.
Maybe we'll submit this one, you submit this one.
This one is really for practice, okay? But at some point, I'm going to give you a quiz similar to this style in class quiz. And I have it. So be ready. I'll let you know the events, but likely next to Wednesday or the following Tuesday. So practice with this. I'm giving you exam questions. Any other questions? For mini exam, we still have a student who needs to take. So I'll probably release tomorrow afternoon. But
I heard the average is pretty good. That's good. That's a testament to your guys' dedication to learning the bugs and the drugs. It's important. If you have bug drug knowledge down, ID is much more manageable. Okay. And it's a skill. It's knowledge that you don't want to let go. You want to continue to learn it and know it. All right. Really quick before I forget, I will post a quiz that'll be due Sunday night on the beta-lactams. Okay. And again, too, it's a familiarity quiz. I want you to look at something and I want you to be able to associate it with this or this or this. For this one, if you want to use your notes, I don't care. Okay. All right, moving forward. So we made mention of the fact that ceftaroline or ceflaro has the ability to trigger this allosteric site, which then tricks the transpeptidase enzyme into revealing the serine residue that subsequently then gets acylated by our cephalosporin pharmacophore. Okay. All right. What else can we do to say cephalosporins to enhance their activity against some pretty nasty enzyme producing organisms? And we can continue to develop cephalosporins with side chains and decorations that might decrease the affinity of the drug for the enzyme active site. But one of the other interesting approaches that has really become important over the last couple of years is combining the cephalosporin with a beta-lactamase inhibitor. And one of the early examples of this was the combination of a drug called ceftolozane that was paired with tazobactam. Zerbaxa, I think, is the trade name for this one. Zerbaxa, ceftolozane, tazobactam. First, let's look at the structure very briefly. Again, no secret here. Pharmacophore, aminothiodiazole ring, gram-negative coverage. Amino group, this is the dimethyl acetic acid variety that you see in as trienam, antigen, and ceftazidime. Okay. And then coming off the 3' position is this really weird looking side chain. All right, just look at the side chain for a moment. First and foremost, consistent with the other anti-pseudomonal cephalosporins that we made mention of, is the positive charge. Okay? That positive charge has a role. That role is to help get this drug through pseudomonal porins. Okay. Increasing the permeability is this basic amino group. Right. So again, polarity and basicity seems to be correlated then with enhanced penetration through the porins. And then the sum or the composite of that side chain, all of it put together, has been suggested to help protect the drug from entry into beta-lactamase, in particular the AMP-C beta-lactamase that Pseudomonas likes to produce. Okay. Now, I can't speak to how often, if ever, this drug is being used, but what's your experience recently with ceftolozane tazobactam?
This drug is indicated multi-drug resistant pseudomonas. So for as the treatment of resistant pseudomonas, probably this drug is the best, most potent drug. But I know a little other area in bigger cities, they are using this drug. They have to use this drug.
Thank you. Questions about Zerbaxa or ceftolozane? Hopefully not coming soon to a pharmacy near you. And then we're going to shift over to the carbapenems. All right. Are there other interesting combinations? Are there other cephalosporin beta-lactamase inhibitor combinations out there? Absolutely. Avicaz, again, is an important one. Ceftazidime, and then avibactam, excuse me, getting old. That's an important beta-lactam, beta-lactamase inhibitor combination that confers protection against a wide variety of beta-lactamases. And we'll talk more about that as we move forward. But for now, I want to shift gears and mention the carbapenems. Okay, carbapenems, thionomycin is an old metabolite that was identified years and years ago. Okay, and thionomycin, unfortunately, wasn't amenable to clinical use because it didn't have the stability that we needed to package it up in a vial, mix it up then in a piggyback, and then inject it into the patients. So the nucleophilic side chain coming off the 3' position precluded its use clinically. The other liability associated with thionomycin is that our kidneys synthesize and secrete a particular enzyme that may or may not even be physiologically important to us, but what it does do is hydrolyze or open up carbapenem rings. Okay, the enzyme dehydropeptidase 1 is a renal enzyme And it actually attacks and opens up the ring, thereby degrading carbapenems. So that was a liability that we had to overcome as well. If we're going to take a lead molecule like that and develop it for clinical use. What did we do? What was done to overcome these two problems? Well, you can modify the structure of thianomycin to decrease or reduce the nucleophilicity of the amino group coming off the side chain. That's the first thing that we can do. It enhances stability. And then there was an inhibitor of dehydropeptidase 1 that was identified called cilastatin. Combining cilastatin, which has absolutely no antibacterial activity, with imipenem, this modified thianomycin derivative, ultimately afforded us then with primaxin. Primaxin, that was the first carbapenem that became available for clinical use. And then imipenem inspired the production of some of the latter carbapenems as well. Here's the structure of imipenem. And here's the amine, I-M-I-N-E, seen in imipenem, which has decreased nucleophilicity. When we combine imipenem with cilastatin, cilastatin inhibits that dehydropeptidase 1 in the kidneys. So what that does, guys, is that increases the urinary presence of imipenem. And that's important in particular because there's a lot of people that present to the hospital with severe UTIs, okay? And then that was successful for the production of primaxin. After some additional studies, learning more about the enzyme, learning how to manipulate the structure of the carbapenem scaffold, what was discovered is that if you insert a methyl group, a beta methyl group, on the carbapenem scaffold, you can reduce its affinity for that dehydropeptidase enzyme. It no longer is a substrate, and as such, you no longer need to incorporate cilastatin in your drug mixture. Right? So meropenem or merum is a standalone product. Ertapenem is a standalone product. Okay. The difference between a carbapenem and a cephalosporin is hopefully somewhat obvious to you at this point. Notice that you have the 4-membered ring, the beta-lactam ring, and here it's annealed to a 5-membered ring, a pyrrole ring, okay? And there is no sulfur in the ring system. The sulfur is exocyclic, right? So it exists outside the ring. The back end of these molecules all have a hydroxyethyl side chain, and the variability then exists coming off the 3 position, okay? And that hydroxyethyl side chain ends up being important, and I'll tell you why in a couple of minutes. Okay? Carbapenem's very water soluble, typically a little bit smaller relative to some of the cephalosporins, and as such, they pass through porins well. So that predicts good gram-negative coverage. Up to this point in time, all of the carbapenems are IV, although we do have some oral agents in development, and they do distribute well. I have here, I forgot to delete this, not used for meningitis. Well, perhaps not used for meningitis as initial therapy. If you come to realize that the offending organism causing meningitis is resistant to one of the preferred agents, then one of the carbapenems might be appropriate, okay? But not necessarily up front. We'll talk more about that later this semester when we get to meningitis. Renal elimination. So again, too, this is something that you're always going to screen as you get these orders in your pharmacy. And then at this point in time, you guys can predict the resistance mechanisms without a doubt. New Delhi metallobeta lactamase, class B enzyme, and other Metallo-beta-lactamases have the capacity to open up carbapenems, okay? IMP and VIM as examples. Loss of porins. Right, loss of porins confers resistance to the carbapenems. So if we modify or remove the porins in our gram-negative organism, our carbapenems can't get in. Right? And I'm not familiar with a molecular test that's rapid in nature that can identify porin loss as the resistance mechanism. Okay. And we also have a constellation of efflux pumps that can take the carbapenem from the periplasmic space and pump it right out. Okay. From a coverage perspective, carbapenems are the drug of choice for, when I say, you say carbapenem. Good, thank you. When I say ESBL, you say, oh, I love it. Do carbapenems cover gram-positive organisms?
Yes.
Yes, they do. Do carbapenems cover MSSA? Yes. Do they cover MRSA? Carbapenems, MRSA. You in? No? Are you folding? Which one? Who says yes? Okay, and who says no? And who's like, I don't know. A couple of you. Good. Okay, so we're not going to use carbapenems for MRSA. Though there's some interesting studies out there that look at combining carbapenems with other agents to treat MRSA. Results are still pending on that. How about gram-negative coverage? Do you get good gram-negative coverage with carbapenems? I would argue yes. What about anaerobes? Do carbapenems afford you with anaerobic coverage? I have a yes here. Do I get a second? Yes. All in favor? Everybody. Perfect. All right. Anaerobes. Good. Are carbapenems stable to AMP-C? We know that they're stable to ESBLs. Could you use a carbapenem to treat an AMP-C producer? You say yes. You say yes. All of you? Dr. Lewis? Yes. Good. All right. So now summarize this in terms of spectrum. Are these narrow or broad? Very broad. Very broad. Okay. Is this something you want to put somebody on initially and keep them on if not necessary? No. Nope. No, no, no. All right. Do these drugs cover Pseudomonas? Carbapenem, Pseudomonas. Yes or no? One more time. All but one. All but one. Okay. And what's the exception? Can't do it with a straight face. Good. What's your little trick? Everything except ertapenem. Except ertapenem when it comes to Pseudomonas. All right. All right. Geez, do I do this or not? I'm talking to myself. Don't mind me. I'm answering myself too. Oh, that looks terrible. We're going to start over. All right. So this is a carbapenem that is localized in a beta-lactamase enzyme. Right. This carbapenem, whatever one you want to pick, I don't care right now, has been accepted as a substrate into this beta-lactamase. And then this beta-lactamase has successfully attacked the beta-lactam bond and opened it up. As such, we have an acyl enzyme intermediate. Now, the next step that this enzyme wants to do is try and bring in a water molecule to attack the carbonyl carbon in the ester. And as that carbonyl carbon in that ester bond gets attacked, it's going to hydrolyze the ester, release the hydrolyzed carbapenem, and then it's going to regenerate the active site. That's what the enzyme wants to do. Okay. But what we see is that this hydroxyethyl group, as a component then of the carbapenems, does some interesting things. What it ultimately does is it interacts with and skews this de-acylating water out of position. The de-acylating water wants to be right here, so it can attack the ester bond. But that hydroxyethyl group punches it away, and now it can't attack that ester bond. Okay, so the hydrolyzed carbapenem is much more stable in an ESBL active site or in an AMP-C active site. So it persists for a prolonged period of time. Okay. What questions or concerns do you have about the beta-lactams up until now? Anything crop up, come to your mind? I know you guys got to look at it. I know you got to study it. There's certain things that I can address right now. Okay. Having said that, then let's shift gears. We've got a little bit of time left to glycopeptides. All right. Glyco meaning sugar, and then peptide, as suggested, peptides. All right. So glycopeptides are cyclic peptides that have some sugar residues associated with them. All right. The prototype was teicoplanin. We don't use teicoplanin here in the United States. We use vancomycin. So vancomycin is our glycopeptide of interest. Now, we could arrive at vancomycin naturally. We could do some semi-synthesis with vancomycin to arrive at its structure, but by and large, it was a fermentation-derived product. In fact, if you go back 40 years ago, a lot of people attributed the renal toxicity associated with vancomycin to impure drug. I think it was called like Mississippi mud. If you Google Mississippi mud, there'll probably be a story about vancomycin and toxicities associated with that. The purification process is far better now. We get very, very pure drug. Did that eliminate the renal toxicity associated with vancomycin? No, it still exists. All right, so that tells you there's a drug-related toxicity occurring. Glycopeptides like vanco, they're cell wall synthesis inhibitors. However, they do not bind to and inhibit penicillin binding proteins. They bind to a different aspect of the developing cell wall. And the molecular weight of vancomycin is in excess of 1,000 Daltons. So it's a larger molecule. And because of its size, it lacks the capacity to pass through a porin. Right? It's too big. It can't get through a porin to inhibit cell wall synthesis. And as such, we can only use vancomycin clinically to treat gram-positive infections. Okay. Mechanistically, a drug like vancomycin is the equivalent of a ball cap for D-alanine, D-alanine. Right? It sits right on top of that C-terminal aspect of forming cell wall, and by virtue of its presence, the C-terminus can't get into the active site of the penicillin binding protein, and it can't get acted upon by the serine residue. And positive infections, it sequesters D-alanyl, D-alanine, and it binds to D-alanyl, D-alanine through some interesting H bonding interactions. So I want to focus your attention on the left side of the screen. This is our cyclic glycopeptide, vancomycin. And then here, in here, is D-alanine, D-alanine. And remember, the penicillin binding protein serine residue wants to come up and attack that particular carbon to zipper the peptidoglycan together. However, look at all these different interactions that are occurring between the drug. There's 5 separate H bonding interactions that are occurring between the drug and then this D-alanyl D-alanine unit. Okay, the most important H bonding interaction is the one occurring here between the amide amino group and then this carbonyl function. The carbonyl function here with this lone pair of electrons is an H bond acceptor, and then the amide nitrogen is the H bond donor. This affords then a very strong interaction between the drug and the target. These other ones are important, but not nearly as important as that one in the middle. And when we successfully do this, we can inhibit cell wall synthesis and we can have a bactericidal effect, theoretically. Okay. Out in the environment, there's a variety of genes that are referred to as VAN genes, V-A-N, VAN A, VAN B, VAN C, and so on. And all of these VAN genes contribute then to the organism's ability to arrive at cell wall through different metabolic schemes and different metabolic precursors. One that's of clinical significance for us is the acquisition and then the subsequent expression of the VAN A gene. And what the VAN A gene does is it allows bacteria to synthesize peptidoglycan using a different starting material. Classically, we like to use D-alanyl, D-alanine as our starting material to represent the C-terminus. When that happens, we're in good luck. We can use vancomycin if we have to. However, when the VAN A gene is being expressed, what the bacteria do is they shift. They stop using D-alanyl, D-alanine as the starting material for peptidoglycan. What they do is start using something called D-alanyl, D-lactate. D-alanyl, D-lactate. The endpoint for the bacteria is the same. It can still generate transpeptidation reactions and cross-link peptidoglycan. So the bacteria don't really care that much. But what's the functional consequence of this gene on vancomycin's ability to bind? Hopefully it's obvious to you without me talking too much more about it. Okay. We want this carbonyl group as our H bond acceptor to bind to this oxygen in that ester bond. Okay, well, an ester bond and a carbonyl group are both going to be H bond acceptors. There's no H bond donor in D-alanyl D-lactate. Okay. This amino group and that proton have been removed and replaced with an oxygen. We're going from an amide to an ester at the same spot. As such, we have a significant decrease in affinity of vancomycin for our target. And that results in vancomycin resistance. In certain strains of Enterococci, Enterococcus faecium in particular, have this gene, and it's very difficult to treat. Okay. Visa, vancomycin intermediate susceptible Staph aureus. And worse yet, have you come across any vancomycin resistant Staph aureus? Have you come across that yet? Literature or even at your site? In dialysis patients. Interesting. Okay. So intermediate susceptible and vancomycin resistant Staph aureus. Again, it's concerning. Is Visa and VRSA a consequence of the VAN A gene? Maybe at some point, but I'd have to dive in a little bit more and see what's going on there that lends to that resistance. Okay, you've heard MIC creep with vancomycin, right? We like our MICs for vancomycin and MRSA to be 1 or below. As it gets above 1 and closer to 2, we get really concerned about the efficacy of the drug. What is going on? What's going on with Staph aureus and its cell wall that decreases vanco affinity, lending to an increased MIC? Methicillin-resistant Staph aureus. If it's not the VAN-A gene, what else can be going on inside that bacterium? What is it doing or producing that might lend to this elevated MIC?
It could be making decoys of the dealanine.
One more time.
Making decoys.
Decoys. I love it. A decoy. What if all of these little whiskers coming off the bacterial cell represent a D-alanine fragment? And what if then vancomycin gets tricked into capping all of these, yet we still have the normal D-alanine that we're trying to cap as well? You're going to need more drug, aren't you? Right? So the MICs are getting elevated as a result of something like this. Decoy production of D-alanine. Right? Good. Vancomycin is not a benign drug. Okay, it does require some interesting therapeutic drug monitoring. When I grew up, we would just draw trough levels. We never drew peak levels. And we would adjust dose based on trough levels and renal function. Nowadays, you use Bayesian, calculations and programs to generate the AUC to MIC ratio or something like that. And I leave that for the experts because I'm allergic to that stuff. Nonetheless, you still get nephrotoxicity. You can get ototoxicity, and then we can get infusion-related reactions. It doesn't happen all that often. And I've seen online some of the pictures associated with vancomycin infusion-related reactions occurs on the chest, on the back, on the face even. It's pretty nasty looking, and it's largely a result of just the infusion itself. Slowing down the infusion or pre-medicating might be ways to circumvent this infusion-related reaction. It's also important to make sure that and your hospitals probably do this already. Heck, they probably buy the Vanco pre-frozen 1 gram and 200 ml. So 5 milligrams per ml is the maximum concentration for peripheral infusion of Vanco. And it's typically infused over an hour still, but all right. So that's the glycopeptide. We've made some derivatives of these glycopeptides that have evolved into what we'll refer to as the lipoglycopeptides. So we still have the sugar, we still have the peptide, but now we have a lipophilic tail associated with these molecules. Right? Telavancin, iridovancin, and then dalbavancin are the lipoglycopeptides. And these are pretty amazing molecules in the sense that they've got these long half-lives necessitating only 1 or 2 doses on a, maybe like a weekly schedule. Dalbavancin every week. Is it iridovancin, just 1 dose? I mean, it's pretty remarkable. It's expensive, but there's a trade-off. If you give this patient 1 dose now, you can discharge them. You don't have to have them come back every day or twice a day for the next week to get outpatient parenteral antibiotic therapy. So you have to wait. Do we pay the money up front now for the drug, or do we have them keep coming back time and time and time again? Up to you. What's unique about these drugs, though, again, is the presence of these lipophilic modifications that contribute to their prolonged half-life and contribute then to their anchoring in gram-positive organisms. Right? So telavancin, oritavancin, and dalbavancin all have this lipophilic projection. And as the drug's encountering a bacterial cell, it'll make its way through peptidoglycan cell wall. It'll insert that lipophilic tail into the cell membrane. And then the rest of the molecule is just hanging around and then probing, looking for that D-alanine side chain to anneal to inhibit then cell wall synthesis. Right? So mechanistically identical to that of vancomycin. These side chains have affinity, I believe, for albumin. They stick to albumin quite tightly, and they slowly dissociate from albumin. So that's a component, perhaps, as to why they have such long half-lives as well. Okay. Dr. Lewis, can I ask you a question? What is your experience or use with some of these newer lipoglycopeptides? Are they pervasive in your practice, or are they used sparingly?
As mentioned, I only see dalbavancin in the ER setting. So when patient comes with, for example, skin infection requiring IV vancomycin therapy, so treatment, requires 5 to 7 days of IV therapy. Instead of admitting patients for IV vancom, if we give dalbavancin 1 dose in ER, then we don't have to admit the same user. So there's a criteria who can receive dalbavancin. But because of the long half-life, we don't have to give multiple doses, 1 or 2 doses. So that's the utility. Telavancin had some more serious side effects associated with. So I don't think the clinically widely used at this time. But some other institution, I know that also they use oritavancin instead of telavancin.
Perfect. Thank you. Questions about the lipoglycopeptides? My guess is, for those reasons that were just described, you might see these being used more and more. Okay. All right. All right, we're stepping away from cell wall synthesis inhibitors now. All right. Covered the beta-lactams, we covered the glycopeptides and lipoglycopeptides. Now we're going to start talking about some other agents. And the first one that I want to make mention of is daptomycin or cubicin. Don't get confused with daptomycin's mechanism and then that of the lipoglycopeptides. It works a little bit differently. Right? Daptomycin is a lipopeptide. Right? It's a cyclic molecule that is lipophilic in nature. Right? And mechanistically, what has been discovered is that this lipopeptide has the ability to bind to bacterial cell walls, sort of aggregate with itself and generate or poke holes in the bacterial cell membrane. So as it pokes holes in the bacterial cell membrane, ions can leak in, ions can leak out. And what you see is somewhat of a depolarization effect inside the bacterial cell that has been suggested to interfere with DNA, RNA, and protein synthesis. So it's a hole puncher is really what it boils down to. I think it likes to bind to phosphatidylglycerol in bacterial cell membranes. Daptomycin is used for gram-positive infections, skin and soft tissue infections. Daptomycin is used for salvage therapy for endocarditis when caused by certain gram-positive organisms. There's data out there to support daptomycin's use for Staph aureus bacteremia. And we also use daptomycin, again, for vancomycin-resistant enterococcal infections. Okay. I don't have the structure here. I can provide that to you if you like. It's in the notes as well. I think what's important is just to recognize the name. Cubicin, daptomycin, lipopeptide. Here's the mechanism. Here's its place in therapy. Okay. Yes, sir.
So because of the mechanism like poking holes in the membrane, that's why it doesn't have gram-negative coverage, since it would poke holes in the outer membrane, not the true plasma membrane.
Correct. Correct. Yes. And what you'll note too is there's some interesting studies out there. Daptomycin actually has to bind to calcium, and then the sandwich that's formed between daptomycin, calcium, and then the bacterial cell membrane is critical for its ability to localize to the cell membrane and then hang out with its friends to poke the holes. Other questions? All right. Okay, and then lastly, the sulfonamides. Again, too, folic acid. Where do we get our folic acid from as humans? In the diet. Good. Organisms, bacterial organisms, the preponderance of them make folic acid using substrates and enzymes. So if we can identify and inhibit those specific enzymes, we can inhibit folic acid. If we inhibit folic acid, we decrease the downstream production of thymidine, which decreases DNA synthesis, and that can lead to bacteria cell death. That's what we're hoping for. Sulfonamides, sulfamethoxazole, look like and mimic para-aminobenzoic acid, which is a starting molecule in folic acid synthesis. And remember, para-aminobenzoic acid attacks dihydrotoroate diphosphate in the enzyme active site of dihydrotoroate synthase. And in doing so, forms dihydrotoroic acid, which subsequently becomes tetrahydrofolate after a glutamic acid is added. And then down the road, it gets converted to a one-carbon donor, which donates a methyl group to uridine to form thymidine. Okay, so what are we doing? We're trying to inhibit this step here, which inhibits the formation of that and everything else downstream. Okay. Oh, that looks horrible. It's nauseating to look at this. But nonetheless, when bacteria make folic acid, guys, that's just not good enough, all right? The folic acid has to get worked upon, and it gets worked upon by a couple different enzymes. Folate reductases are required to convert folic acid into tetrahydrofolate. All right? And then tetrahydrofolate gets methylated by a hydroxymethylase enzyme to afford us with this intermediate N5N10-methylene tetrahydrofolate. And then that's the one carbon donor right here. Rich carbon between these two nitrogens gets attacked by thymidine and the enzyme thymidylate synthase to generate that thymidine, which is used for DNA synthesis in bacteria and in our cells as well. If we inhibit this enzyme or this enzyme, we can also suppress bacterial folic acid synthesis. Right? So we have a two-pronged approach here. That's my alarm. Let's decrease folic acid synthesis. Let's decrease the production of tetrahydrofolate through two different systems. And in doing so, what we have is a synergistic effect on decreasing thymidine synthesis. What drugs do this? Very briefly, and then we'll be done. What drug inhibits folic acid synthesis? Yep. Sulfamethoxazole, sulfonamides. And then what agent is an antibacterial that inhibits dihydrofolate reductase in bacteria? Charity, what were you gonna say? Talk to me. Trimethoprim. We'll just abbreviate that TMP. What a great combination. What a great pair. All right. We will stop here. Thank you for dealing with me today. I appreciate it. Pick it up on Monday. I will send you the equivalent of a study guide. I will post a quiz for you within the next day or so. We'll have that due on Sunday night. And then we'll pick things up on Monday. We'll finish up with this. The fluoroquinolone slides are posted. The macrolide slides are posted. I'll get to the aminoglycosides and tetracyclines as well. Monday's going to be a sprint. All right. But again, I'll tell you what I want you to know. Thank you.